here to the long head of the triceps, you can see in the diagram. And when it comes in the middle of the arm, what does it do? It changes direction. Goes from where to where? What happens in the middle of the humerus? The groove? Radial groove. So what does it do? So right now it's here. Okay, it's coming here. And it needs to go on the lateral aspect. So behind and medial, it goes into the radial groove and it comes out laterally. But before coming out, it pierces something. What is it called? Lateral intermuscular septum. Okay. And in the radial groove, it is goes along with profunda brachii artery. So when it pierces the lateral intermuscular septum, it then stays close to the humerus, almost stuck to the humerus, and then it descends down up till the elbow. So now it has reached up till the elbow. You can see here in the radial groove, this is the medial side, this is the lateral side coming down. It's here and it's now going to stay here. Now in the elbow, does it stay anterior or posterior? Okay, it is in the posterior aspect. Now it has to come in the forearm. Does it stay posterior or anterior? Anterior. So it is crossing in front of the lateral epicondyle. Okay. And as soon as it crosses the lateral epicondyle and enters the forearm, it divides into two of its terminal branches. What are those? Loud. Superficial radial nerve and what? Posterior interosseous nerve. Anterior interosseous nerve is given by median nerve. Yes. Okay. So we'll also discuss the radial tunnel, but when it comes in the forearm, divides into two. In the radial tunnel, the PIN, which is mainly the motor branch, and SRN, which is mainly the sensory branch. Okay. Now, what all does PIN supply? Or what does the whole radial nerve supply? So when it's in the arm, around the axilla, it is already given branches to triceps, all three heads of the triceps. When it descends further down near the elbow, before crossing the elbow, it supplies two muscles. Which are those? Brachioradialis and Anconius, and one more. ECRL. What is ECRL? Extensor carpi radialis longus. What does it do? Extension of the carpal link. What joint? Extension of the wrist joint. Okay. But ECRL is located on your radial side. If ECRL is working, the wrist will go in this direction. It will not go up. Okay, it's go in radial direction. If extensor carpi ulnaris is working, your wrist will go into ulnar extension. Okay, so that you have to remember. So these muscles are already given: brachioradialis, Anconius, ECRL. Now it crosses the elbow in front of the lateral epicondyle, divides into two, and now all the supply is only given by PIN, not the main radial nerve trunk. PIN supplies what all? All the remaining muscles of the forearm and wrist and the finger extensors. So what are those? And extensor pollicis longus. Yes. What does it do? Extensor pollicis longus. Extension of the thumb. Pollicis means thumb. Okay. Extensor pollicis longus. What else? Extensor carpi ulnaris. Extension of the wrist. What else? Forearm muscles. Brachioradialis already supplied. What else? What lifts the little finger? Extensor digiti minimi, minimal muscle, minimum finger, extensor digiti minimi. What raises the index finger? What raises the index finger? Finally, hear me. Naam? What raises the index finger? फोरआर्म मसल के कोई भी नाम बता. हो गया. और नहीं, वो नाम ही गलत बोला है. एक्सटेंसर डिजिटोरम पॉलिसिस कुछ नहीं होता. What raises the index finger? Extensor indicis. Now what raises all the fingers? What raises all the fingers? Extensor. Extensor digitorum starts with C. Communis. ओके. और ECRL पहले सप्लाई हो गया था, क्या बच गया? Whenever there is a longest muscle, there is also a brevis. So extensor carpi radialis brevis, that is also remaining. तो वो PIN ने सप्लाई कर दिया. अब बचा क्या? Sensation part. Okay. So sensory part is covered by SRN. Where does it supply? What is the area of radial nerve in the hand? What does radial nerve supply, sensory supply in the hand? Thumb where? Dorsal. Dorsal aspect of thumb, index finger, middle finger and half of ring finger. So 3.5, lateral 3.5. So now that you know where all it is supplying everything and what all it is supplying, you can see, you can guess the clinical features of the injury. If the injury happens at wrist, if the injury happens mid forearm, if the injury happens elbow, if the injury happens mid arm, if the injury happens in axilla, everything will affect different muscle and accordingly all the functions and sensation will be lost. So we begin with the highest point. Radial nerve gets damaged in the axilla. What all is gone? What all is gone? All the function of what muscles are lost? Extensor muscles are lost. You can flex the elbow and with the gravity the hand will go down. Okay. So this function will still be there. But if you keep it like this function will not be there because the triceps is also gone, the wrist is also gone, the fingers are also gone. This is happening in the axilla before supplying the triceps muscle. Okay, now it has supplied the triceps muscle, it has crossed the radial groove and it has reached the elbow. So after crossing the radial groove it gets damaged. Now what happens? Now what happens? Before crossing the elbow, after crossing the radial groove. अभी तो डिस्कस किया था किसको कहाँ सप्लाई हो रहा है. I think it's given in her phone. Let's ask her. Yeah. What is the question? Go answer. Come. Come. Take your stuff also. You've given attendance? The job is over. It's okay. Last time also it happened. Go. Okay. Yeah. What does it supply after crossing the radial groove? And and yes. So everything except the triceps is on. So now what is the patient able to do? Elbow extension. What is he not able to do? Wrist extension. So most common point of radial nerve getting damaged is the radial groove and distal to it. So most of the time when radial nerve injury does happen, your elbow function is intact, but your wrist and finger function is lost. So the commonest thing associated with radial nerve injury is wrist drop, finger drop. Okay, now it has crossed elbow. Okay, now it has crossed elbow and it is reached in the forearm. So the radial nerve has already supplied whatever it supplied. Now only the PIN nerve will supply. So the PIN gets damaged. What all functions are lost? Now एक्सटेंसर कार्पा रेडियालिस लॉन्गस तो पहले ही सप्लाई हो गई थी भाई. हाँ ये इसलिए आगे बैठ जाना चाहिए, शायद कुछ सीख लो, शायद. हाँ उसका फंक्शन रहेगा नहीं रहेगा? उसका फंक्शन लॉस हो जाएगा. उसके अलावा सारे एक्सटेंसर्स ऑफ रिस्ट और फिंगर्स गए. सो विल द पेशेंट बी एबल टू डू रिस्ट एक्सटेंशन? यस बोला. Yes, the longus is already supplied. So the wrist will go in the radial deviation, but the wrist extension will be there. Okay. So this can be a false finding. If you do not examine properly, you will see the patient is doing like this and you will think that the PIN is intact. But you have to make sure the hand is straight and it goes up, and also the finger drop will still be there. Okay. So patient will be able to do this, but will not be able to do this. So make sure you check for finger extension and wrist extension in proper position. Okay, so it has gone forward and PIN is injured. Now depending on what level the PIN gets injured, the muscles will be getting involved. If there is no PIN injury, the patient is only complaining of sensory loss. What does that mean? Superficial radial nerve is getting damaged. So where does superficial radial nerve lies? Superficial radial nerve originates where? After the elbow. Okay, and brachioradialis muscle is there, so it stays beneath the brachioradialis muscle in its entire course. Okay, so from here it keeps on going like here, and around the wrist it gets divided into two parts: the medial nerve and the radial nerve. The medial supplies your this part. 1, 2, 3 fingers, 2.5 fingers, and the the radial part supplies the thumb, the dorsal aspect of the thumb. That much detail you do not know, you need to know. Just you need to know the radial nerve supply area. Okay, so this we have already discussed. What happens in the axilla? There will be weakness. So how does it usually gets damaged in the axilla? Radial nerve. What is that called? Saturday night palsy. Okay, sleeping with your hand lying down and getting compressed with the armrest. Also crutch paralysis. People who use crutch for a long time, they can also experience this. So it's, what kind of injury is this? What kind of injury is this? There are 3 types of injuries: neuropraxia, axonotmesis, neurotmesis. What type is Saturday night palsy and crutch paralysis? कौन बोला? कोई बोला? जोर से बोल दो भाई. क्या होती है? न्यूरोप्रैक्सिया क्या होता है? एक्सोनोटमेसिस क्या होता है? न्यूरोटमेसिस क्या होता है? क्या टॉपिक डिस्कस कर रहे हैं? चलो ये तो पता है। अभी कहाँ पे चल रहा हूँ? हाँ, क्या होती है वो? न्यूरोप्रैक्सिया क्या होता है? Nerve compression. So this is the nerve getting compressed. So this is a neuropraxial injury. Can you all see this? लास्ट वालों का तो मतलब नहीं है, बट आगे को समझ में आ रहा है? So this is done. We'll have tingling and numbness all over the arm, and this is in the spiral groove. This is the most common area, and then this is the injury to the PIN. You can see the supply of SRN here. Nerve getting divided, supplying thumb and the index finger, middle finger, half of ring finger. So depending on what part of radial nerve is damaged, we have three types of injury. One is the radial tunnel syndrome, what is the PIN neuropathy, and one is the SRN neuropathy. So radial groove, radial tunnel. This is your radial tunnel in the beginning of the forearm. This is brachioradialis and ECRL, which is forming the lateral border. Your pronator teres is forming the medial border, and your biceps tendon is the floor. This is your radial nerve getting divided into two parts. So any injury to the radial nerve in this area is radial tunnel syndrome. Now because it has both parts still intact, the SRN and PIN, it will have both the components, motor as well as sensory. But motor nerves are more resistant to injury. Okay, so they are more resistant to injury. So this syndrome will have less of motor effects and more of sensory effects. Whenever motor is less involved and sensory is more involved, you will have more pain. You will have tenderness. If motor is involved, you may not have tenderness because the muscle cannot feel anything. Okay, so if you press in the radial tunnel in this condition, there will be prominent focal tenderness. These are all the points you have to use to differentiate radial tunnel syndrome, to differentiate lateral epicondylitis, to differentiate PIN injury, differentiate SRN injury. So remember, there is prominent focal tenderness in radial tunnel syndrome. Both motor and sensory functions are there. Tingling, numbness will be there. Normal neurologic function will be there. Normal neurologic function means what? Patient still has sensation and patient still has all the movement. There will be weakness, but there will be movement will be present. So weakness of Payne's grip and MCB joint. It is most commonly seen in male, manual laborers and bodybuilders. This is radial tunnel syndrome. Next you have the PIN neuropathy. So SRN is fine. There will be no sensory component, only motor component. So motor, whatever muscles it is supplying, those will be damaged. Okay, we have already discussed that. And usually how does it happen? It happens because of lipoma, synovial chondromatosis, panicin, rheumatoid arthritis, either septic arthritis of elbow or vasculitis. So basically anything which can cause compression of the PIN. Then we have the SRN. So only the sensory component is involved. The wrist extension, finger extension, elbow extension, everything will be normal. So in this also there will be tenderness, and it is most also known as Wartenberg syndrome, also known as chiralgia parastatica, also called as handcuffs neuropathy or wristlet watch neuritis. These are all the names of SRN neuropathy. Symptoms are ill-defined pain or numbness or both in the radial part of the hand, the area supplied by the radial nerve, and symptoms may increase during pronation of the forearm. Why during pronation of the forearm? Why during the pronation of the forearm? When you pronate, these muscles get taut. It gets taut and causes further compression of the superficial radial nerve. So how will you diagnose this? What are all the methods to diagnose radial nerve injury? How will you diagnose? ऐसे पूछ लो. इतने से क्या पढ़ो? हाँ. So अगर ऐसे इमरजेंसी में आया रेडियल नर्व इंजरी का पेशेंट लेके, तो कैसे बचानेगा? नहीं पहचाने, orthopedician बुला दो. How will you diagnose? How will you diagnose? How will you diagnose? जोर से उधर सुनाई देना चाहिए.
सर फिजिकल एग्जामिनेशन करेंगे.
Good. So you will do physical examination, which is the most important thing to diagnose these nerve injuries. Your clinical history and your examination will give you everything you need. Your diagnostic methods, which is the ultrasound, CT, X-ray, MRI, they are only 50% positive. Not every time positive. Not every time you'll see an injury on the X-ray, because it's just a compression of the nerve by the muscle or any soft tissue tumor. MRI is also not very, don't have any prominent features, and ultrasound also same thing. They are all just additive effects. They are not diagnostic. Clinical history, note down the sex, the symptoms, the occupation, because we saw certain injuries are more prone in certain occupations. So once you have done the examination, you need to note down the point of tenderness, the motor sensory examination, the provocative test. We'll see what those are, and the Tinel sign. Radiographs not useful, MRI may be useful, but mostly useful for surgical planning. And EMG can be used to differentiate between the closed direct differentials. EMG is what? Electromyography. Tells the electric potential of the muscle. So if PIN is damaged, the muscle EMG will show something. If SRN is damaged, your EMG will be normal. Okay, every nerve has its own provocative test. We'll only focus on these two. So radial nerve, which is the PIN, this arcade of fossa, what is that? So when radial nerve crosses the elbow and it pierces the supinator muscle after differentiating into PIN, SRN, there is a thick fiber of supinator muscle, like a tendinous fibers of the supinator muscle will get attached on the elbow. So this nerve can get compressed in that tendinous fibers. They are very thick, okay, and any inflammation of those fibers can cause this problem. So this is the usual entrapment site. What will be a provocative test? You press over the supinator muscle. Supinator muscle is here. You press over the supinator muscle. You create a resisted supination. Hold the arm like this. Hold it in this position. Ask the patient to turn to supinate. This will do what? It will make the supinator muscle very taut. And if it becomes taut, the muscle becomes thick. It can cause compression of the nerve. Or you can do a resisted long finger and wrist extension. This will also make the muscles here tight, and that can also cause compression and create all the symptoms that we need. So that is for the PIN. If for the forearm you have to check at the junction of brachioradialis and extensor carpi radialis tendon. So this is your brachioradialis and this is your extensor carpi radialis. So somewhere around here. बस 5 minutes. Okay, so yeah, so at this junction if you press, you will have the tenderness. So certain provocative tests you can also use for this. Now comes the treatment. So what will be the treatment? What are the most common form of injuries of radial nerve? Neuropraxia, exonotomesis or neurotomesis? Neuropraxia. How do you treat neuropraxia? How do you treat neuropraxia? कुछ डैमेज होता है क्या न्यूरोप्रैक्सिया में? तो कुछ ट्रीटमेंट की जरूरत है. तो क्या चीज की जरूरत है? रेस्ट की, पेशेंस की, काउंसलिंग की. So that is the major treatment for all the three conditions: radial tunnel syndrome, PIN and SRN. Our goal is only to relieve the pain, allow normal nerve glide, that is the movement of the nerve during the motion, and regain independence with ADI. ADI is activities of daily living. So treatment consists of conservative, which is rest, give it rest, activity modification. So all those laborers or bodybuilders, whatever function they are doing which is causing the symptom, you have to tell them to reduce it, to stop it, or do it differently. you can use NSAIDs or corticosteroids to reduce the pain and the inflammation. And then for better nerve glide, you can use stretching, strengthening and nerve gliding exercises. This is the major stay of treatment for all this condition. Only if it is neuropraxia. If it is an accident or a fracture and that has caused axonotmesis or neurotmesis, treatment is different. Treatment will be that time surgery. You can either surgically decompress, but this is only done when conservative has failed for at least 3 months consecutively. Do not jump to surgery immediately if the patient comes with wrist drop and you immediately explore the radial nerve. That is not true. You have to wait, give it 3 months, start conservative treatment. If this is not done, then you go for surgical decompression. Or if you got the X-ray done and you can already see a compressive mass like a bony growth which is pressing on the nerve, then you can intervene immediately. Then there is no need to wait. Next we have the PIN, more or less same as RTS. Treatment will be same as RTS. NSAIDs has no role here. Why? Because the pain is not a usual symptom. Why the pain is not usual symptom? Because it is a motor nerve. So pain is not a usual symptom, so NSAIDs does not work here. Surgery can be delayed for 4 to 6 months, and either it can be delayed up to 4 to 6 months, or you can do immediate surgery if the patient has already presented late. And when it presents late, there will already be muscle atrophy because the patient has not been doing his wrist extension or finger extension. So either of these two conditions you can go for surgery. Next is the SRN. Again, only the sensory component is involved, and usually it is self-resolving. You do observe. Non-operative same is rest, activity modification, rest splints, NSAIDs, everything same. Other modalities, because it is sensory nerve involvement, you can start nerve stimulation and you can do ultrasound massages. Okay, they are helpful in sensory part, not with the motor part. And again, if you do all this for 6 to 8 months, there is still no improvement, you can go for surgery and you can surgically decompress the nerve. Okay, so in conclusion, you have to identify it early. So identify it, diagnose it. The earlier you start treatment, the better results there will be. You should know the site of compression, only then you can identify the nerve, identify the problem, and for that you need to understand the anatomy. Next is diagnostic studies are not reliable. You have to always correlate with your clinical findings. So your clinical findings are more important than any diagnostic tool here. And surgical decompression, which is mostly curative, the patient does improve, but it is always the last resort when conservative treatment has failed. Okay, done. So what does this show?